every other section, we'll take a little bit of a break. Okay, so in order to have a sense of how to use drugs, you have to, of course, understand some of the basics of how we categorize pain. The nociceptive model is some kind of damage is happening to the body, and this wire here is my elegant nervous system, and it is transmitting the signal to the brain. Right, so the nervous system is doing what it should do. That's nociceptive pain. Kind of a representation of the nervous system can be a computer, and when your computer is broken, it's a painful experience. But when your internal computer is broken, that could be neuropathic pain, the nervous system malfunctioning. So nervous system doing what it should do, nociceptive pain, malfunctioning, neuropathic pain. Okay, so the first question for you, and generally the questions, I don't know if this has been true for all your lectures, are coming before the material that the questions deal with. So what are good strategies for post-op pain control? Choice A is preemptive analgesia, combining different drug classes, using patient-controlled analgesia. Choice B, using intramuscular opioids and anti-inflammatories, plus or minus acetaminophen, combining pharmacological and non-pharmacological modalities. Obviously, as we go through these letters, the choice that we're going to pick is the one where everything is true. Choice C, using patient-controlled analgesia, combining different classes of opioids, combining different classes of NSAIDs or anti-inflammatories. Choice D, using preemptive analgesia, using opioid patches, combining different drug classes. Choice E, preemptive analgesia, using opioids with a PRN dosing schedule of every 4 hours, combining pharmacological and non-pharmacological modalities. So the choice that we want is A, where we're going to, as strategies for post-op pain control, we're going to want to use preemptive analgesia, combining different drug classes, and using patient-controlled analgesia. So some of the things that the choices included intramuscular opioids, which we want to avoid whenever possible in a hospital setting. Shouldn't be hard. Most patients have IVs. Combining different drug classes is a good approach, but generally we don't want to use multiple drugs of the same class. So in most situations, we're not going to want to use multiple NSAIDs or multiple opioids. Patches are slow in onset, cannot be titrated rapidly. Therefore, we don't really use them in a post-op setting. Q4-hour dosing may be appropriate for some opioids, but it may not be appropriate for opioids with shorter clinical durations. Okay, again, as we think about all the various drugs, it's good to think about where they're acting. And one of the key places they're acting is in the dorsal horn of the spinal cord. Okay, and so in the dorsal horn, you have the dorsal part or the sensory transmitting part of the spinal nerves coming into the spinal cord. They consist of different fibers. The small pain transmitting fibers, small as in thin, they tend to synapse in the superficial lamina of the dorsal horn, whereas the larger light touch fibers tend to synapse deeper into the dorsal horn. They have to synapse onto what's called the second order neuron, which I have here in yellow, and then it crosses over the spinal cord and goes up the spinal thalamic pathways. You guys are going to get more neurophysiology, so we won't go deep into this. But it is good to note that under certain conditions, the light touch fibers can sprout new axonal terminals, which can affect the superficial lamina, activating the second order neuron. That may be part of the mechanism behind allodynia. The second order neuron becomes sensitized when it sees intense pain. So now afterwards it's more reactive. Again, part of the process of allodynia. In that dorsal horn, if this is the top being the primary afferent coming from the periphery, this is the synapse now in the dorsal horn, and it has to activate the postsynaptic terminal, which is the start of the second order neuron that's going to continue that pain signal up to the brain. So if we kind of blow that up and look at it, we see that there's, this is obviously a tiny fraction of the different kinds of neurotransmitter receptors that are on these nerve terminals, and the dark ones are inhibitory. So for instance, you'll see a mu receptor here. So if that's activated by an opioid, that'll be inhibitory of the release of neurotransmitters. And we also see mu receptors postsynaptic, and that will hyperpolarize the postsynaptic or second order neuron, so it's less likely to fire. Okay, so you're inhibiting pain both pre and postsynaptically. Now later we're going to talk about other actions of opioids which are not so good, but at least in this view, it's got two mechanisms of inhibition. And you can see there's lots of other potential places to inhibit pain signals. So if we're going to look at pharmacologic strategies for dealing with acute pain, they include preemptive pain control. And whatever you do preemptively, you want to maintain through that immediate post-op period. If you give a patient, let's say, local anesthesia, but you allow that to wear off by the end of the case, so now they're in pain, the benefits of your preemptive analgesia are going to disappear. So you need to maintain good pain control before the stimulus, before the incision, and maintain it through the immediate post-op period. Typically, this is done with local anesthetics, either infiltration or regional blocks or spinal blocks, such as epidurals. Consider multimodal and synergistic approaches. So opioids and anti-inflammatories are synergistic. 1 + 1 = more than 2. So we want to do combinations. You might consider adding acetaminophen as a third drug approach. Note that if you're going to use an anti-inflammatory, the post-op setting is a relatively good setting to consider a COX-2 inhibitor, right? Because COX-2 inhibitors do not have added bleeding risk. They don't inhibit platelets. We'll get more into that. Then you might consider using other drug classes, ketamine, gabapentin, pregabalin. Finally, consider using non-drug approaches, exercise, cooling, heat, stretching, massage, TENS, and frankly, education is sometimes the best. Having some kind of educational module pre-surgery, giving the patient a good sense of what to expect and things that they can do for themselves often helps lower anxiety, and lowering anxiety is lowering pain. If you're going to give an opioid, you want to avoid IM injections. You want to avoid long PRN intervals. You might consider a PCA as a very nice technique to give small but frequent dosing based on the patient's need. Okay, let's dig into some of the different drug classes. So let's talk about anti-inflammatories. So what are their indications? Acute pain, musculoskeletal pain, arthritis, including things like gout, menstrual cramps, headaches, bone pain. They may be more effective for the bone pain of metastatic disease than opioids. Fever, big note there when the patient is not hypovolemic. That's a really important point to know, right? Because anti-inflammatories inhibit prostaglandins, and some of the prostaglandins are what help the kidney maintain perfusion in the hypovolemic state. If you're removing those prostaglandins in the hypovolemic state, they can develop ischemic kidneys. So if you have the typical patient with a fever, throwing up, diarrhea, sweating, okay, you cannot give them an anti-inflammatory. You could give them acetaminophen, but you can't give them an anti-inflammatory until you make them euvolemic. And then salicylates are generally avoided in children under 12 because of Reye's syndrome. Okay, let's talk a little bit about the analgesic impact of these drugs. So this is just showing you that opioids in general, not true of all opioids, but it is true of the pure mu agonists. Pure mu agonists have no ceiling effect. So the more you give, the more analgesia until you lose the patient. Okay, so no effect, no ceiling effect. Anti-inflammatories and acetaminophen do have ceiling effects. So if you take a look at the far right here, this is maybe one of the better established ceiling effects is acetaminophen. Acetaminophen has a ceiling effect at 1,000 milligrams. Right? So at 1,000 milligrams, they've hit maximum analgesia. So taking that third extra strength Tylenol at that point, taking that third one will not give you any additional analgesia, just additional risk. Okay, question. Which of the following is a benefit of the COX-2 selective inhibitors? A, they avoid risk to the kidneys. B, they reduce long-term GI risks. C, they do not impair platelet function. D, they are more effective than non-selective anti-inflammatories. So pick your choice. The answer is they do not impair platelet function. So let's explore the others. Both COX-1 and COX-2, these are the enzymes that convert arachidonic acid into prostaglandins. So both COX-1 and COX-2 enzymes are involved in maintaining kidney perfusion. Therefore, giving a COX-2 inhibitor, and the only one on the market now is Celebrex, so giving a COX-2 inhibitor does not maintain safety to the kidney. So that patient we just talked about, that hypovolemic patient, you cannot treat their fever or their pain with Celebrex until you make them euvolemic. Decreased GI risks are pretty well established in the early phase and are not well established beyond 6 months. So generally we do not know if the risk is lower for long-term use of COX-2 inhibitors. And the efficacy of the COX-2 inhibitors, again, Celebrex, is similar to those of the other NSAIDs. So basically you will find all NSAIDs, all anti-inflammatories, have pretty similar clinical efficacy. Of course, doses will vary, but their clinical efficacy is about the same. Okay, so I was alluding to this a minute ago. Arachidonic acid is the base material that COX-1 enzymes and COX-2 enzymes will transform into prostaglandins. And the prostaglandins via COX-1 are involved in cytoprotection, of the GI tract, platelet activity, and renal function. So if you leave this alone, then you're going to leave GI cytoprotection intact, you're going to leave platelet activity intact, and you could potentially leave renal function intact, except for you see the same problem over here. So COX-2 inhibition can also impair renal function. But when you do block COX-2 function, you are blocking to some degree inflammation, pain, and fever. So we've talked so far about arachidonic acid via the COX-1 pathway, via the COX-2 pathway. There is yet a third pathway, the lipoxygenase pathway. The lipoxygenase pathway does not produce good things. So it produces like slow-reacting substance of anaphylaxis that can trigger bronchospasm. And it also produces leukotrienes that can negatively impact the arterial lining. This may be the mechanism behind why all anti-inflammatories increase cardiovascular risk. Because we're blocking this pathway. We're blocking this pathway, COX-1 and COX-2. We're driving more arachidonic acid into the lipoxygenase pathway, leading to more arterial lining destruction. Note that if you give a COX-2 selective inhibitor, so you're just blocking this pathway, there is a risk that you're going to produce more thromboxane, causing more vasoconstriction and platelet aggregation. That may be why early COX-2 inhibitors, people may remember Vioxx and Bextra, were taken off the market. Interestingly enough, the current one, Siloxybib or Celebrex, does not seem to have any higher cardiovascular risk. So this is mainly for your information and in your books, that you can see the names and the groupings of different anti-inflammatories. We have the salicylic acids, of which aspirin is the sort of flagship one, but there are others. And then there's other groupings, propionic acids, acetic acids, enolic acids, phonemic acids. So all of these, maybe there's a value to knowing groupings, and that is some people theorize that if one doesn't work, your next one should be in a different group. I don't think there's any clinical evidence for that, but there's at least some logic to it. Okay, so let's look at this issue of being COX-2 selective. So first of all, the vast majority of anti-inflammatories fall into this non-selective COX inhibitors. Almost all. There's just a few exceptions. We already talked about Celecoxib, which is Celebrex, which is COX-2 selective, does not impact COX-1. Then there are 3 anti-inflammatories which have more weight for COX-2 inhibition and are relatively weak COX-1 inhibitors. And a little later from now, we'll address if there's benefit to that. And then sometimes it's interesting to know there is such a thing as a COX-1 selective inhibitor, and that's low-dose aspirin, which is why low-dose aspirin is used as a platelet inhibitor, because that's what COX-1 does, for cardiovascular protection. Okay, question for you. What are common risk factors for GI complications with anti-inflammatories? Choice A, age greater than 60. H. pylori status being positive, irritable bowel syndrome. B, positive H. pylori, age greater than 60, concomitant use of nicotine. C, use of nicotine, use of steroids, irritable bowel syndrome. Left a word out there, but it should say irritable bowel syndrome. D, a high carbohydrate diet, use of multiple anti-inflammatories, use of nicotine. E, positive H. pylori, age greater than 60, osteopenia. Correct choice is B, positive H. pylori, age greater than 60, use of nicotine. So these are all risk factors for use of anti-inflammatories. There are others, such as use of multiple NSAIDs, including aspirin. And it is not true that irritable bowel syndrome, a high carbohydrate diet, or osteopenia are risk factors for the GI complications of NSAIDs. So we discussed a little bit how arachidonic acid could be shunted to the lipoxygenase pathway, producing leukotrienes, slow reactive substance of anaphylaxis. Anti-inflammatories may also react with other medications, such as anticoagulants. It's a double interaction. Right? So one is you can alter the blood levels of the anticoagulants, but in addition, if they now have a bleeding ulcer and they're on an anticoagulant, that bleeding ulcer turns into a hemorrhage. Kidney damage, especially in the hypovolemic state. Stomach problems, gastritis, and ulcers. These are all the risks associated with anti-inflammatories. Elderly patients are particularly sensitive, and you should start generally with half of the typical dose. There's a condition known as aspirin-exacerbated respiratory disease, AERD. Aspirin and other anti-inflammatory induced respiratory reactions in patients that typically have an underlying asthma or rhinitis sinusitis type of condition. The mechanism seems to be related to the arachidonic pathway, maybe more production of that lipoxygenase pathway. Aspirin and NSAIDs that inhibit cyclooxygenase type 1 cross-react with each other. Both are potential problems for this. But COX-2 selective inhibitors almost never cause reactions in patients who have this problem. Typically, they can be taken safely. A second type of problem that you might see with aspirin and NSAIDs is an exacerbation of urticaria and angioedema. This occurs in maybe a third of patients who have chronic urticaria. Drugs that inhibit COX-1 all interact and cross-react and cause this reaction. And again, COX-2 inhibitors are typically less risky for this. Reaction number 3, IgE-mediated reactions, typically again seen as urticaria or angioedema or anaphylaxis. These appear to be specific to a particular drug, and then it's not likely that that other NSAIDs will cross-react and produce the same reaction. It's usually drug-specific. And then a fourth reaction of urticaria or angioedema, but not fitting the other categorizations, is typically caused by, if the patient's going to get this, any drug that inhibits COX-1. Okay, so why might we be interested in COX-2 selective? Well, all of those reactions you see, generally the COX-2s are safer. There is a reduced risk of GI ulcers. As we talked about, we only know that relatively short term. There is no platelet inhibition. So I say here, okay with Coumadin, meaning you're not increasing, you're not inhibiting platelets. Now, it's not completely okay with Coumadin because you still can get some GI risk. So if they do get an ulcer, a bleeding ulcer, again, because they're on Coumadin, it could turn into a hemorrhage. It is not true that they spare the kidneys, so you can't use it for that reason. As we've been talking about, there is a lower risk of bronchospasm. These two, when these slides got reformatted, it got underlined instead of crossed out. These should be crossed out, meaning these are no longer on the market. And Celebrex dosing is typically in the range of 200 to 400 milligrams a day. So in the days of Vioxx, which is rofecoxib, there was a large study called the VIGOR study that showed that over time, those patients developed higher and higher risk of cardiovascular events. And that led to it being taken off the market, and similarly with Bextra. Naproxen also shows some elevation because all anti-inflammatories do, but not nearly the same as the VIGOR study showed for rofecoxib or Celebrex. There's a large Danish observational study which showed that when you take a look at NSAIDs in general, but actually they were looking specifically at diclofenac, there was an increased risk of death or myocardial infarction up to 5 times greater than those who do not take NSAIDs. The risk was dose-related. Again, that dose relationship shows, or is at least strongly suggestive that there's a causal association. There's no safe treatment window for NSAIDs in patients who already have cardiovascular disease. Of all the NSAIDs, the one with the least cardiovascular risk seems to be naproxen. Ibuprofen has a higher risk of stroke associated with it. Question: which of the following strategies will decrease the risk of using anti-inflammatories? A, celecoxib because it's associated with greater cardiovascular risk than other NSAIDs. B, use meloxicam, a partial COX-2 selective drug, because it is associated with less GI risk. Avoid naproxen because it's associated with the highest cardiovascular risk. Add a PPI to treatment, proton pump inhibitor, with celecoxib, especially in elderly patients. Nothing can be done to decrease the GI risk of NSAIDs. That's choice E. Adding a proton pump inhibitor to celecoxib, especially in elderly patients, does decrease risk. Some of the other points that were not true. So celecoxib has similar cardiovascular risk to other NSAIDs. Meloxicam, which by the way is Mobic, has similar GI risk to other NSAIDs. So even though it's partially COX-2 selective, there does not seem to be GI sparing. Naproxen is the lowest cardiovascular risk, not the highest. And the GI risk of NSAIDs can be decreased. It should be by choice of the NSAID, depending which one, or by adding proton pump inhibitors. So when we look at efficacy comparisons, a lot of people think that Celebrex or celecoxib is not as effective, but actually it appears to be similarly efficacious to other NSAIDs. The partial COX-2 inhibitors all seem to be similar to the non-selective ones. If you compare among the non-selective ones, they're all basically the same in terms of efficacy. And very interestingly, if you look at diclofenac and compare the topical solution versus the oral, roughly equally efficacious. When we look at risks, and we're looking now at celecoxib or Celebrex, with regard to upper GI adverse effects, there does appear to be a short-term advantage, but this is not demonstrated. It doesn't mean it's there or not there. It means we don't know beyond 6 months. Risk of myocardial infarction and other cardiovascular, cerebrovascular events are roughly the same with the non-selective ones. No increased risk of hypertension or heart failure compared to the other NSAIDs. They all do this. All NSAIDs increase risk of heart failure and hypertension. Celebrex was not associated with an increased fracture risk. If you look at meloxicam, again, a partial COX-2 selective, no advantage over the non-selectives. Okay, so it's not a reason to give it because you're going to save GI problems, but also no increased risk. Nabumetone, which is Relafin, compared to non-selectives, it had a lower short-term GI risk, so that's actually an advantage. Again, short-term, we don't know long-term. And Etodolac, another partial, may have benefits, but we really don't know. It hasn't been studied. There does seem to be a slight increase of fracture risk with long-term use of Etodolac. So all non-selective NSAIDs are associated with similar GI risk. All non-selective NSAIDs, except for naproxen, associated with similar cardiovascular risk. Naproxen is lower. Diclofenac has the highest rate of affecting the liver, and may have the highest overall, and ibuprofen may have the highest risk of fracture. So what about this idea of adding proton pump inhibitors? So if you look at patients that are 75 years and older, there were fewer GI complications when you added a proton pump inhibitor to Celebrex. So you're basically doing two GI protective things. You're using Celebrex and you're adding a proton pump inhibitor. Two short-term trials found no statistically significant difference between Celebrex versus a NSAID and a proton pump inhibitor. Right? So in other words, if you do one benefit, on the one hand you could do Celebrex, or on the other hand you could do a non-selective plus a proton pump inhibitor, roughly equal degrees of protection. Add both together and you seem to get more protection. Now when you add an NSAID to the use of aspirin, you're giving aspirin for the benefit, for cardioprotective benefit, low-dose aspirin. The question is, if you add an NSAID, do you wipe out that benefit? And basically we don't know because the studies conflict. One study showed that it could interfere. Two studies did not find an increased risk of myocardial infarction. So I think we just don't know. So all these patients who are taking low-dose aspirin in order to prevent or decrease the risk of coronary artery disease, if you add an NSAID, we don't know if you've wiped out that aspirin benefit. Ketorolac, under the name Toradol, is probably the most widely used of the IVIM NSAIDs. It does have an analgesic ceiling at about 15 milligrams. So giving higher doses is probably not accomplishing anything. In the elderly, you want to generally reduce your dose to about 10 milligrams, and you may want to increase your interval. And patients with renal impairment may need even lower doses and less frequent doses. In the beginning, I asked you the question about their GI risk factors that may increase the risk of NSAIDs. So just to review those, positive H. pylori status, excessive dose of NSAID, use of multiple NSAIDs, counting aspirin as one of them, all increase risk. Age increases risk. A history of peptic ulcer disease increases risk. The use of corticosteroids and anticoagulants increases risk. I don't think I see it here, but also nicotine increases risk. Okay, question. When treating patients with inflammatory bowel disease, which of the following is the correct approach? So you have a patient who's got inflammatory bowel disease. Arthritic conditions are common in this group, so you may want to give an anti-inflammatory. So what choices here are, which of these choices is correct? A, NSAIDs are beneficial for the inflammation affecting the bowel. B, when they are needed, when anti-inflammatories are needed, coxibs are the best choice. C, for patients with irritable or inflammatory bowel disease, it should be inflammatory, and arthritis, it is best to use opioids and avoid all anti-inflammatories. D, arthritic conditions rarely coexist with inflammatory bowel disease, so it is rare to need anti-inflammatories. E, for inflammatory bowel disease, the choice of NSAID depends on whether the symptoms are constipation or diarrhea predominant. When NSAIDs are needed, coxibs are the best choice, is the proper answer. Non-selective NSAIDs can cause flares of inflammatory bowel disease. When anti-inflammatories are needed, coxibs are the best choice. The rate of flares is the same as for placebo. Thus, they may be preferred even over opioids, which have their own risks. In general, they have risks, and they also have risks to the gut. Arthritic conditions commonly do coexist with inflammatory bowel disease. Okay, so we see a lot of comorbidity with arthritis, sacroiliitis, ankylosing spondylitis. NSAIDs do, here I say possibly, I think there's a fair amount of evidence that they are associated with exacerbations of the inflammatory bowel disease. Coxibs, again, Celebrex is the only one on the market, appear to be safe with flare rates similar for placebo. What about topicals? So diclofenac is really the primary available topical. It's available in a patch, which is trademarked as Flector patch, in gel, trademarked as Voltaren, and as a liquid drop, trademarked as Pensaid. So topicals have less systemic absorption, and therefore can can avoid some of the adverse drug reactions of oral anti-inflammatories. So when we look at some of the evidence out of the Cochrane database, we find that topical diclofenac, topical ketoprofen, piroxicam all work reasonably well for strains and sprains. For hand and knee osteoarthritis, topical diclofenac and topical ketoprofen used for 6 to 12 weeks does reduce pain by at least half in a reasonable number of people, not everyone. Okay, so we are done with section 1, but let's go